So, as I mentioned, nutritional care process helping the RD to use their critical thinking and if make the best interdisciplinary decision making. Okay, so NCP, the nutritional care plan, has 4 steps. Okay, so they are nutritional assessment, nutrition diagnosis, nutrition intervention, monitoring, and evaluation. Okay, we'll go detail for each headings, but this is the model. Okay, this is NCP. You must guys have already seen this picture in your cross book. So as I mentioned, the first one is nutritional assessment and reassessment, second one is diagnosis, third point is intervention, and the fourth and final step is nutrition monitoring and evaluation. Okay, so we'll go to the nutrition assessment. So once you get the information from based on the nutritional screening, we obtain the appropriate data to identify a nutritional related problem or what is the cause of that problem. Okay, by like you like when we study, you must have seen ABCD, something like that, like anthropometric, biochemical, something like that. Okay, so the basic categories: anthropometric measurements, which is including height, weight, BMI, weight history, which means like did he had any recent significant weight loss or not significant weight changes, something like that. Okay, biochemical data or medical procedures and tests, including lab data, something like blood sugar or electrolytes level or hemoglobin level, something like that. Or test means, or maybe procedure, something like somebody has a modified barium swallow, or maybe gastroscopy, endoscopy, or something, any procedure they did, they have for any particular reasons. And the next category is nutrition focused clinical findings, such as how do they look, do they have visible fat wasting is there, do they have any swallowing difficulty, are they drooling food while they eating. Like when you are working in a hospital, someone is eating a food and you notice that they are drooling the food, then that's a physical finding, right? They have some issues with the swallow, those things. And diet or nutritional related history, like we get the diet history, right? What did you eat for last 24 hour, or maybe on a typical day, what do you eat? Or do you avoid something, are you lactose intolerant, do you avoid something because that's from prohibiting you from your based on your religion or any reasons. And the last point is client history, which is medical history. This HX is stands for history. Okay, medical history, family history, social history, anything like that. Okay. And the next, so when we finish the assessment, next we'll go for the nutritional diagnosis. In this piece, we are identifying a disease or condition from its signs and symptoms. Okay, I know it may be a little confusing. I can go detail in the future slides. Okay, so nutritional diagnosis, we usually write it in a PES statement. Okay, PES means problem, etiology, signs and symptoms. Okay, so I have given 2 examples of PES statement. First one is inadequate oral intake, related to intake less than 50% of estimated nutritional needs, as evidenced by significant weight loss of 7% over the past 1 month. So, inadequate oral intake, that is the problem. Okay, so that is the P in the PA statement. Related to means why? Because the intake is less than 50% of estimated nutritional needs. That is the reason. Okay, and how do you know that? That means the signs and symptoms. Why? Because they lost more than 7% of weight in the last 1 month. Okay, that's how you have to write a nutritional problem. Not just like, oh, there's someone has a weight loss or something. That's not the correct way. Okay, the second example is swallowing difficulty. That is the problem related to recent stroke. That is the etiology, or that's a reason, as evidenced by diagnosis of aspiration pneumonia. So someone has aspiration pneumonia, what do you should know? Oh, someone has a swallowing difficulty. Otherwise, usually food or fluid won't go to the lungs, right? So there is a reason. So that is that's how you have to find out what is the nutritional problem. Okay, we don't write any medical diagnosis, we actually find what is the nutritional problem. That is the reason for we going to the nutritional diagnosis. Next step is nutrition intervention. Nutrition intervention is actual plan. Okay, we're doing some plan to implement or to like help them to get some of the nutritional related behavior, said whether they have behavioral issues or environmental condition or health condition, whatever it based on the problem, we are planning the action. Okay, so intervention has pieces: planning and implementation. Planning is like we setting the goals or we determining the outcomes. I can explain. So someone has weight loss, significant weight loss. So then our goal is has to be regain what is the weight they lost. How do you determine? I mean, how do you see the outcome? By monitoring their weight every monthly or something like that. Okay, that's an example. I can explain it more in the coming slides. And the implementation is how you are communicating this goal to the patient, like how you are going to implement that. Okay, by the nutrition intervention has the four main domains. So that's why food and nutritional delivery, they're like you work in a hospital and you're giving us like a diabetic diet, or maybe glucerna, someone has a weight loss or someone has a wound, you're giving that food to correct their problem, to heal their wound. Okay, next one is nutrition education. So someone, again, you have a patient in hospital and you are training, like you're giving a education material and you're instructing, okay, you know what, every 3 hourly you have to eat these things. You're just giving an instruction that's very peripheral. Okay, you're giving some knowledge. That is nutrition education. Nutrition counseling is more depthful, like you are giving an hour session with the patient, you're making a rapport with the client, you are helping them to make a positive change in their life by adapting healthy balanced diet, something like that. Okay, and the next is coordination of nutrition care. That is something like that you are referring to other facility, or maybe someone has a like poor accessibility to food, then you're referring to a food bank, something like that. Okay, and the last point is nutrition monitoring and evaluation. This is why we are monitoring or evaluation. This is determines how effective is our interventions. Are they meeting the expected goals? Are they meeting the whatever, like for example, we were looking the weight for somebody who has a weight loss, are actually they getting gaining weight, or are they losing weight? So this is the point, like we have to monitor and evaluate how good or how bad they are doing actually, based on what is their food and nutritional history outcomes, like what they were used to eat and what they now eating, or what were their blood sugar level before it was 12, are they better now or worse. Anthropometric mission, I just mentioned the weight loss or weight gain, or are they still avoiding such foods or something like that. Okay, so the points I mentioned here, you guys may already know that: assessment, diagnosis, intervention, monitoring, and evaluation, right? So implementing all those points in a case study. Okay, this is a case study actually I did during my college studies. So I like to share that with you guys. So this is like a 45-year-old male with the type 2 diabetes, came for a glycemic control. Okay, that is the case, that is the referral you getting from a doctor to see a dietitian. Okay, so for this guy, past medical history is he is diabetic since last 10 years. He also has hypertension, high cholesterol, and obesity. Family history, both parents are diabetic. Social history, he works as an accountant, live with a wife and kids at home. He smokes 1 to 2 cigarettes per day, alcohol 2 to 3 glasses of vodka per week. Physical activity, he's fairly sedentary. He's an accountant and he don't do any particular exercise. Okay, And anthropometric height is 175, waist circumference is 102, usual weight is 95. Okay, he has gained approximately 15 kilos since last 6 months. So the lab value is this little different from our Indian blood work, but generally this is a little bit high blood sugar, high cholesterol, something like that. Okay, and the medication, this is a little different from Indian medication, but basically this is for hypertension. Statin is for cholesterol, omeprazole is for hypertension, Glumetza is for blood sugar, Novamax is insulin. Okay, and this is his diet history. Basically, he eat coffee with a sweetener, bagel with a peanut butter, some fruits, some Greek yogurt, coffee, 2 p.m. again, big sandwich with a bag of chips, fruits, diet cola, water, then 5 p.m. cappuccino with the scones, that's kind of cake, or let's say biscuits. 8 p.m. again, some meat with the starches, again, some slice of bread with the leafy vegetables and a glass of wine or beer, and 11, 11 p.m. a big bowl of popcorn with some fruits or cereals. That's his diet history. Okay. Based on the previous information, now we're going to implement the NCP. Okay. So based on the anthropometric measurement, we are calculating the BMI. Okay. When you see the BMI, you can see he is obese class 2 category, right? Very high risk of developing health problems. And he, as I mentioned, he has gained 13.6 percentage weight in last 6 months. So we do have a standard. Someone has a 5 percentage weight change in 1 month, 7.5 percentage in 3 months, 10 percentage weight changes in 6 months. We consider as a significant weight change. So this guy gained 13.6 percentage in the last 6 months. So which is a significant weight gain. Weight circumference is 102, increased risk of developing health problems. So in this anthropometric measurements, BMI and waist circumference are in high risk category. Going to the lab assessment, as I mentioned, the blood fasting postprandial blood sugar, A1C, both are high, showing poor glycemic control. Okay, high blood pressure, he is hypertensive, and cholesterol is high. Medical assessment, so it's basically we have to see why. So, okay, Glumetza is the anti-hyperglycemic agent, and but do we have to say whether is there any he take alcohol, right? So you see, avoid alcohol, but he's still taking alcohol, so that is actually doesn't not a good thing. But basically you have to see, is there any drug nutrient interaction? That's what we have to, what the point we are looking from this medication assessment. Okay, and Novamax is an insulin, Ramipril is antihypertensive, statin is for cholesterol lowering. Okay, depends upon what medication they are taking. The next is, in the assessment, we have to check the diet history based on what he was eating from the dietary recall. He's basically eating excess calorie, excess sodium. Okay, which is like we have to, and protein is fine, and he's eating less vegetable and fruits. That's the dietary assessment for 1 day. Okay, so using Mifflin-Singer equation, his requirement is 2700 and he is eating 3680 calories. So from that, what do you understand? He is taking extra calories, right? Fluid, I just use 1 ml per kilocalorie, which is 2700 ml, which is okay. Protein and fat, each one you have to calculate based on, or maybe um, Indian recommended RDAs you have to follow. Okay, and so by this we are finishing the assessment point. Now we go to, so you using this, you got some ideas that he has excess calorie, excess sodium, less vegetable. These are the nutritional problems we seen so far. So we are trying to make a PEA statement. Okay, so based on that, I just made excessive energy intake, that is the problem related to consumption of large portion of meals. Okay, that is the etiology as evidenced by usual diet history and his current BMI. Okay, so that's how we have to write the PES statement for someone has excess energy, not just like a okay, he's eating not like a regular. So in this, so anybody, somebody is writing from India or someone is writing from Canada or America, everybody can understand what we meant. So that's why the beauty of following PES statement. Okay, so next PES statement is excessive sodium intake related to high consumption of processed food and quick service restaurants, as evidenced by a client's report, an estimated sodium intake of 4,000 milligrams compared with the recommended sodium intake of 1,500 micrograms. So, adult supposed to have 1,500, but he's taking 4,000, and he is hypertensive, and he's taking medication. So, which could be a another problem, nutritional problem. Okay, so I just use these two, and I'll show you how we are progressing with the other steps. Okay, so this is the nutrition intervention or plan. Okay, we identified the problem. He's eating excess calorie, he's eating excess sodium, so we trying to implement some plans. Either this is basically, you can make long term goal or short term goal, depends upon the condition. Okay, so this case, the first long term goal is reduce energy intake 500 to 1000 kilocalorie to facilitate a weight loss 0.5 kilogram per week, or having further weight loss 5 to 10 percentage in 6 months. So it is a long term goal. Okay, so how you're going to attain that? So there should be a goal and how you are implementing. Okay, planning and implement. Plan is the goal, implementation is the recommendation, how you're going to achieve that goal. To pack a lunch from home with 1 to 2 servings of vegetables, whole grain bread, pasta or rice, and 1 serving of lean protein. That means the plate model. Half the plate has to be vegetable, 1/4 has to be starch, 1/4 has to be the meat protein. Okay, for a minimum 2 times per week, and have less processed food. So when you cook something from home, we know what we can control the ingredients, we know how much we are putting, right? But over buying something from outside, we don't know. For taste, they will be adding so many things. So that could be one of the realistic recommendation. Other recommendation is to reduce portion size of meal. For example, instead of having 12-inch sandwich, have 6-inch sandwich. So for the diet record, he was having 12-inch sandwich. So we could recommend, maybe is that possible to 6-inch rather than avoiding it, maybe limiting could be a possibility. So that's a long-term goal. And short-term goals. So to decrease sodium intake to a range of 1,500 milligrams per day, that is the recommended sodium intake. Okay, so he is actually taking 4,000 milligrams. So how to reduce? What are the possible options? To replace processed food with the fresh and low sodium homemade meals. The processed food is itself is high in sodium, so replacing that with the fresh food, that's a good idea. And read nutritional label to choose low sodium food, which is like less than 5% of daily value. Like, we all know, like anything more than 15% is a lot, anything 5% of daily value is less. So maybe he should start reading the nutritional label, could help him to buy foods which are low in sodium, so that if we cook food from home, okay, these all interconnected recommendations. And the next recommendation is to add 2 servings of fruit as a snack in the afternoon. Instead of having pumpkin scones, maybe eat a fresh fruit. Okay, and the next goal is like you remember that he has gained 13 percentage in last 6 months. So, and he is a accountant, he is having a sedentary life. So second goal, he would like to was to increase physical activity to help to meet the Canadian guidelines, which is 150 minutes per week. Okay, this is basically based on what does the patient want. Based on that, we have to custom the goal. The recommendation could be maybe join walking club to have 20 minutes brisk walk 1 to 2 times per week to start, then gradually increase. That could be, we have to emphasize on the following sessions, okay? Not start with something with the first session itself. Next is join to the gym and use equipment under supervision of a trainer. And the other short term goal is like, remember, he is a diabetic, right? So he's a diabetic patient and he's a poor sugar control. So something we have to attend immediately. So how? That's the moment of our job, like we have to educate him how to distribute carbohydrate throughout the day to control the glycemic levels. Okay, how we are going to attain that? Introduce low to medium glycemic index food to the client. And the next option is introduce consistent amount of carbohydrate each meal, which is 60 to 75 gram, and a snack 15 to 30 grams with the like in every 3 hours or something like that. And enrolling on a diabetic education class regarding carbohydrate distribution throughout the day. So these all things, it's like immediately doable so that he can start knowing about that and can control the diet what he's eating. And based on the goals, how we are going to monitor or evaluate his progress. So some of the suggestions are schedule a follow-up with patient for 3 weeks time to monitor food intake by checking the food record. So basically we are asking them to keep a food diary, or maybe we could ask the 24-hour record when he come for the next appointment. And we could monitor his weight. So then we are seeing, so he is 110 kilo, how he is doing now. If he started doing exercise and he's eating healthy, he might have lost like maybe 1.5 kilos in 3 weeks, right? So we could process whether is that our goals are good enough or we need to change it or something like that. Okay, and follow up on lab tests suggested, like lipid profile or fasting blood sugar level in 1 month, or cholesterol level or A1C in every 3 months, based on, like, A1C is only change applicable for every 3 months. So based on what test we are looking at, we could follow up on that. So that's how we do the monitoring. Yeah, that's actually the sessions I want to say it. Mm, if you have any questions, or do I need to repeat, I am happy to explain. That's your turn. If I was quick, I could repeat it.
Good morning, madam. Is my audio fine with you all? Good
Can you repeat
morning.
that?
Yes, please.
Yeah, this is Dr. Kritika from Vellalar College for Women, E Road. I thank organizers for organizing this webinar, and I thank Mrs. Surya M. Kottaram for passing on this information and inviting me for this webinar. Thank you, Surya. And regarding this, I have a question, ma'am, to you.
Go ahead.
It was a very nice, informative, nice presentation, ma'am. Thank you so much. And if at all the patient is with insulin treatment and he is obese and also diabetic, how can we ask them to proceed with calorie intake? And is there any suggestions you could do, since because you might be an expert with this clinical side? We are not that much. That's my question.
Okay. So I just want to paraphrase your question. So someone is diabetic, taking insulin, and you are asking how to control their calorie. Is that the question, Kritika?
Yeah, ma'am. Yeah, exactly.
Okay. So his blood sugar level is how good or bad is managing, and is that newly started insulin, and you have to check that diet history. Okay, and it is very important, like if it's what kind of insulin he is taking it, and is that with the meals, or so what is the, instead of cutting the calories, you have to educate how to distribute the carbohydrate throughout the day. So you should have the his height and weight, and to see the calculate the BMI and calculate his nutritional requirements. Let's say 1500 calorie. Okay, so how you are going to distribute? A good breakfast, moderate lunch, decent dinner, but HS snack. HS snack is very important. Those who taking even the metformin or especially insulin, those people should not miss their HS snack. So instead of cutting so much calorie, you have to emphasize on distributing carbohydrate throughout the day. Did I answer your question? I'm not sure. Did I answer your question?
Yes, ma'am. But if we are distributing in such case, will it help him to reduce his weight if he is obese too?
Of course, because what equation you are using? Because for for diabetic management, for sure we won't use the high calorie, right? So like
Okay.
I remember that we use the factor method, like 20 calorie, 20 to 25. Even if someone is underweight and diabetic, we use 25 calorie. But someone is overweight and he's diabetic, we use 20 calorie, right? I still remember we using that equation, right? So using 20 calories itself help promote weight loss. So it's actually dual help. It can control your blood sugar level. It also can boost to lose some weight. So it's based on what equation you are using, based on their BMI. Are they underweight? Then you're okay to use the 25 calorie. But if somebody is obese, use the 20 calorie or even 15. If it's like morbid obese, you're okay to use the 15 calories, right? The factor
Okay.
method.
Okay, ma'am.
And
Yeah.
that itself, it's helping to manage the blood sugar level, and it will promote the weight loss. And when the blood sugar level is controlled, or it's not so not over the moon, then doctor can adjust the insulin. It's actually so,
Thank you.
so many helps.
Thank you. Thank you so much.
Thank you.
Good
Any
morning, ma'am.
questions, dear?
Good morning, ma'am.
Yeah.
Thanks for the wonderful session. My name is Madhumita. I'm working at the National Institute of Physical Medicine and Rehabilitation. I just had a question about the PES statement. I work with a lot of children with in the spectrum, that is autism spectrum disorder. So we do a
Mm-hmm.
lot of elimination diets here to identify potential food intolerances. So
Mm.
some of these kids who come in, they have normal height and weight, so they do not have any other related, nutritional diagnosis. So when we
Mm.
do an elimination diet, how do we actually coin the PES statement for them? Like, because it's not
Okay.
necessary that they need to be intolerant to the foods being tested.
Okay, so the PE statement is a big vast topic. So
Yes.
I just touched it, but PS has many domains, like intake domains, or knowledge domain, or food acceptability. So this may be this people has food intolerance, so the limited food acceptance, or maybe limited food adherence related to food allergy. You may specify maybe lactose intolerant or celiac, or instead of writing the disease name, you have to
Mm,
write it as a gluten sensitivity, as
mm,
evidenced by maybe weight loss, or maybe diarrhea for last 3 months, something like that. So you write what is the allergy. Okay,
mm,
that is the problem. Sensitive, okay, it's like for they have given a 2-page PS statement, but you can customize based on that, because they haven't said anything like a food allergy related to gluten sensitivity, as evidenced by diarrhea for 3 months, or maybe gradual weight loss, maybe 5 percentage for the last 10 months or something like that. You can customize. It doesn't have to be all the time inadequate food intake or swallowing difficulty. Like, some for example, someone has a pressure ulcer, like, someone
mm,
is with autism or multiple sclerosis. If we get to move, or someone has a dementia, sitting so many times at a, so then have a pressure ulcer. So how we implement the PS at a stage, like stage 2 pressure ulcer related to reduced mobility,
mm,
or maybe poor skin integrity related to um, reduced mobility, as evidenced by stage 2 pressure ulcer in the coccyx, something like that.
Okay. Because
Whatever it
why
is
I
wrong.
mentioned
Hmm.
why I mention this is because some of these children, when we do the elimination test, we actually test a lot of sensitivities. So we are not really sure whether they have this gluten intolerance, because even symptoms like eye contact and all that are there, which is not really recorded in a the PES manual, the nutrition care
No,
process manual doesn't really specify all these symptoms.
no.
So it's okay if we customize it, right?
Yeah, it is okay to customize, but is actually PS statement is made for nutritional problem. Someone with eye
Mm,
contact, it is not a nutritional problem. That is something
mm,
pure medical. But
mm,
if you say multiple allergy, someone has a lactose intolerance or query lactose intolerance, or maybe like they allergic to beef or some anything. So you say you could even write it altered GI function. Someone has a rashes or maybe diarrhea. You could say altered GI function related to consuming possible food allergens. Like
mm.
you can mention it, like a beef, pork, or milk, cheese, as evidenced by rashes, diarrhea, something like that.
Okay, so for example, the Fain Gold diet that some of them we test for that as well, like where we avoid all these preservatives and all that. So
Hmm.
hyperactivity is actually the symptom that is being, as evidenced by hyperactivity. That is the symptom the child is showing. So can we say
Hmm.
the as evidenced by hyperactivity as a symptom? Can we state that?
Of
Because
course,
that's
of
not
course,
really.
of course. Any like you see, I think I mentioned that diagnosis of aspirational pneumonia,
Yes,
that
yes.
is a medical symptom. You can write it a sign and symptom. You can mention the medical diagnosis, like aspiration pneumonia or hyperactivity or uncontrolled blood sugar level or stage 2 pressure ulcer or maybe dysphagia, like some any medical diagnosis. You can write it as a sign and symptom.
Okay, thank you, ma'am. Thanks.
Okay.
Uh,
Anybody else?
Priya, yeah, there are a few
Yes,
questions in the chat box.
yes. Ma'am, can I take up the questions? There are two
Mm,
questions from
mm,
Asia.
mm.
Asia would like to know if there is any tool to assess the metabolic rate of the client. And she would also like to know how can we specialize as dietitians.
Okay, metabolic rates. Okay, so that is actually you could maybe be using the actually tracking the physical activity and the diet history. We could relate it whether actually they are taking 1200 calorie and they are physically active like 45 minutes regular exercise and still they are not eating, then their metabolism could be low. But also diagnosis like hypothyroidism, their metabolism is slow. Someone has a PCOD, their metabolism is low. So health conditions, you have to go with the you have to generalize with the diagnosis actually, or you have to closely monitor what they're eating, what they're exercising, and what is their weight pattern. Are they losing it? But that is common sense, right? Someone is physically active for 45 minutes and they are eating very less, but still not eating, then their metabolism is low. And like nowadays everybody uses the keto diet, right? So for some time they might be losing some weight, but then they won't lose anything. Why? Because their metabolism is stuck. So then they have to eat again. That's again another topic, but then they have to eat to enhance their metabolism, to shake the body, because the body is in like a, it's not moving, its metabolism is stuck. So I don't have any say black and white tool for that, but you have to use your clinical judgment. You have to go through, is there any medical diagnosis such as hypothyroidism, hyperthyroidism, and PCOD, diabetes, abdominal obesity. Those things could be some clue to see that their what is their metabolism. And how can we specialize as a dietitian into oncology dietitian and pediatric dietitian? Okay. In India, maybe you need to work with that, each department, I believe. Here, it is little different. You need, like, I am trying to be a diabetic educator. So, how to be a diabetic educator is I have to work with the diabetic people for 800 hours. Then I have to write a diabetic educator exam. So then I am certified diabetic educator. Same thing for if you want to be a pediatric dietitian, you have to, like, Aspen, like you must have hear about this Aspen or something, or maybe pediatric some specialty. You have to do that course, then write the exam, then you will be a pediatric licensed pediatric dietitian. That's what Canada and America, I think Australia and UK too, doing that. But in India, I'm sorry, actually, I really don't know. I myself, I worked in a renal department, but my first posting was at renal department. So actually, I didn't had any special license or something to work in a renal department. I just trained under Molly ma'am for a couple of months. Then I was independent. That's what actually. I don't know whether I answered your question, Aisha. I see. Yeah.
Ma'am, I actually have a doubt. Since we are in the telemedicine era right now, and we have a lot of counselings being conducted right now, how will we able to, implement the NCP in such a scenario, especially the assessment part, the anthropometric and the clinical? Because now we are forced to do, online consultations or assessments and so on.
Okay,
So
so
how can we take it?
in that case, we have to preliminarily depend on the patient. But if suppose is not everybody has a weighing balance, but they might have a measuring tape. So that's why you have to use the waist hip ratio or something if you can't get the weight. Okay, or maybe even they don't, suppose they don't have a measuring tape. So then we have to ask, is how do you feel? The dress are loose or is it tight? Something, you ask, try to get that information. But the dietary history you can get. You ask, do they have any bowel movement? Is that everything okay? Is that constipated? Skin is dry? Is that any swelling is there? Is the urine is yellow or something? Like you can figure out whether they have any dehydration. So it is possible, and nowadays many of them is working remotely. So the screening, nutritional screening, we could use a MMSC or like the screening tool. We could use different screening tool to get the information. Once you get the information, whether it's remote or on site, doesn't matter. We have to work with the patient to make realistic goals. Like if I say, oh, in this COVID season you have to join the gym, that's not realistic. But they could do means maybe climb the stairs, like maybe 5 times 20 stairs 5 times a week. That may be possible. Like set the realistic goal. That is the intervention. Like you work with the patient to set some realistic goal. You make the short term goals, like okay, Monday, Wednesday, Friday, I will climb 5 times 20 steps. Okay, that's a short term goals. But you doing this for 3 months, you'll be losing like 2 kilos. That's a long term goal. So use the different appropriate nutritional screening tool to get the information, maybe a solution. I think so. Like MMSC, or maybe like in each hospital, sometimes they have like height, or like I say, they don't have a measuring tape, use the waist tape ratio, or maybe approximate weight you could do. Like somebody has like at my hospital, someone has a multiple fracture. No way you can't weigh him. He is bedridden and he is demanded. We don't even know. So we just take the estimated height and estimated weight, and you use the average calorie, like 25 calorie. You see, you ask to the patient that, do you consider as a normal weight? You, or maybe somebody, if somebody asks, oh, do you have, like I always say overweight, so I cannot say I'm normal weight. So the person, you have to depend on the person. It is basically Instead of you giving everything, it's like a two way. Like that's a client centered approach. He has to take that initiative. It's not like you should not do these things. When I came here, I was I I can only say direct approach, morning to idli sambar. That was exactly, I was like that. But when I came here, they said no, you have to change your approach. You have to go for client centered approach. What client want? He want 3 idli or 4 idli. You make the goal based on that. Maybe instead like benefit is there with the client centered or direct approach, both is beneficial. However, if its client is showing that initiative, like you make that rapport with that patient, and he's taking that initiative, so then you will get the result. Maybe little slow, maybe he will reach that goal by 3 months. But if he follow 2 months, like do Italy for 2 months, then he might reach the goal by 2 months. What happening is after 2 months he won't stick with the plan. So as a dietitian, our goal is to implement, like give the nutritional counseling, make a rapport, so that patient can make that initiative or responsibility to make that long standing changes. Did I answer your questions?
Yes, yes, ma'am. Yes, ma'am.
Anybody else?
I have a question.
Yeah.
Uh, Actually, we are not at all the authority to do this clinical assessment, right? So how can we manage this clinical assessment side? ABCD, in ABCD, we are mentioning about clinical assessment now. So how can
Yeah.
we manage this clinical assessment from our end?
So this is the clinical assessment we are, but we are not making any medical diagnosis. We don't have the license. We don't have the judgment skill to make any medical diagnosis, but we can make the clinical judgment. Why don't, like you touch the here and you see some swelling, so possible swelling, something like that. You have to mind your language instead of certainly, okay, this patient have swelling. You might write this patient might likely have some swelling or might have swelling, something like that. But we could write it, but not the medical diagnosis. We don't have license to write any medical diagnosis, but we can do the clinical assessment. We are equipped, we are informed well. So something like that, here you see some muscle wastage, you see that's your critical thinking. So that patient might have some weight loss. That's what you see. Instead of certain, just right, you just do that inclusive language, like so that to protect your license. But we can do the clinical judgment, yeah, but not the medical. You cannot say somebody has like, for example, someone has a consistent blood sugar, high blood sugar level. You cannot you cannot say that he is diabetic, but we could say that consistently high blood sugar level over the past 3 months. We can say that because that's a fact. You have the proof to see that this month, last month, previous month, this guy has a 7.5 blood sugar level. A1C was consistent high blood sugar level. So that is the beauty of PES statement. You are not making any medical diagnosis, but still you can make your point saying that this guy has a trend. So then doctors see that, oh, he was a pre-diabetic or maybe something. Okay, can you give the diet? So it's actually protecting our license. We can work as an interdisciplinary team with the doctor or nurse practitioner, whoever it is making the referral. They have the license to say that, oh, he's a diabetic or maybe hypertensive. You just see what's the trend. That is why we checking the lab. You see, okay, this time is 120 100. Oh, so what was that last time? Just 150 100. Okay, so then you see last two measurement, yeah, somebody had a high blood sugar level, blood pressure level, or cholesterol. The triglycerides is this, or that is why we are collecting. So someone has this is the first time someone has high cholesterol. But if someone has a family history, like my father died of heart attack, my mother died of diabetes, my grand uncle died of congestive heart failure, so there is a strong family history, then even little bit of high cholesterol is an indicator. You have to step in. So this actually, there are some trick that you can intervene based on the data you collected. Did I answer? Anybody have any questions?
If anybody has any questions, you can unmute yourself and ask, or you can put it in the chat box. If not, we will move on to the concluding session.
I could write my email ID. Okay, if anybody has any question or would like to give more information or something, this is my email ID. You can reach me out or ask Surya or Miss Annie if they have my cell number or if it is needed.